Hi friends, from today onward I will be talking about respiratory system examination. Here we will discuss about the history taking physical examinations. First is the disclaimer. This is the case sheet format for history taking. In history taking we have to write down the name, age, sex, residence, occupation, chief complaints in chronological orders. And after that we have to write around the history of presenting illness. For example, if the patient presents with cough, we have to ask him for duration, onset, progression, the variation in the form of diurnal variation, seasonal variation, postural variation, aggravating factors, relieving factors. The patient has cough with expectoration, the duration of expectoration, onset, its progression, variation, diurnal variation, seasonal variation, positional variation, aggravating and relieving factors, the quantity of the sputum, color, smell, blood. If it is blood tinted, how often, quantity, whether it's fresh or altered blood. If the patient has symptoms of dyspnea, its duration, onset, grade, aggravating factor, relieving factor, whether he has orthopnea, trepopnea, platypnea, PND. Similarly, for chest pain, we have to ask about duration, onset, diurnal variation, variation with respiration, aggravating, relieving factors, any other tenderness, associated features like vomiting, tenderness, sweating. Patients with V's, we have to ask for duration, onset, progression, episodic or continuous variation, allergy, skin rashes, aggravating or relieving factors. Patients with fever, we should ask about episodic or continuous nature of the fever, whether it is associated with chills and rigors, grades, aggravating factor, relieving factor, variation, diurnal variation, history of nasal discharge, recurrent cold or epistaxis, recurrent headaches, weight loss, anorexia, evening rise of temperature, smoking, belching, regurgitation of food, hoarseness of the voice. In the past history, we have to ask about asthma, COPD, history of contact with tuberculosis patient, diabetes, hypertension, ischemic heart disease, seizure disorder, loss of weight, whether there is any occupational exposure, sleep, dietary habits, whether taboos, family history. We have to draw the pedigree of at least three generations. In personal history, we will ask bowel habits, bladder habits, appetite, food allergies, smoking, how many cigarettes he smokes per day, smoking index or pack per year, alcohol history, menstrual history, age of menarche, menopause, amenorrhea, oligomenorrhea, menorrhagia history. Then we have to summarize, make the differential diagnosis. In general examination, where we have to write whether the patient is conscious, cooperative, oriented, obeying commands. We have to write down his BMI, pulse. We have to check for rate, rhythm, volume, character, vessel wall thickening, radio-radial delay, radiofemoral delay, peripheral pulses are to be felt or not, blood pressure in all four limbs, respiratory rate, whether it is thoraco-abdominal, abdominothoracic, is it regular, whether there is any usage of accessory muscle. Then we have to check for JVP, SpO2, pain. On physical examination, we have to check for pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. Oral cavity examination, accessory muscles use examination, external markers of tuberculosis, malignancy, and any other feature which is suggestive of respiratory failure. In systemic examination, for example, for upper respiratory tract examination, we will check the nostril for any DNS, polyps, sinus tenderness, tonsils, posterior pharyngeal wall. For lower respiratory tract examination, we will do inspection. In the inspection, we check for shape and symmetry, spine, subcostal angles, trachea, apex, beat, respiratory movement, visible pulsation, or sinus or scar over the chest wall. In the respiratory movements are to be assessed on both sides, right and left. We have to inspect the upper anterior chest wall, lower anterior chest wall, upper posterior chest wall, lower posterior chest wall on both right and left side. While doing palpation, we have to first warm over palms by rubbing against each other before palpation, and we have to ask the patient that he is going to examine or palpating his chest, and he should be comfortable with that, and he should give you the consent. We have to check the position of the spine, any tenderness. We have to check the whether trachea is centered or laterally placed. We have to check for the apex beat and the respiratory movements which we saw in the inspection. We have to confirm it by palpation. We have to check the areas like supraclavicular, infraclavicular, memory area, suprascapular area, infrascapular area on both and right and left side. Similarly, we have to measure the transverse diameter of the chest, anterior-posterior diameter. We have to take the thoracic transverse anterior-posterior diameter ratio. We have to check the chest circumference in both expiration and inspiration. Right hemithorax, left hemithorax, expiration and inspiration. We have to see the chest expansion. We have to find out the spino-scapular distance, both right and left side spinoacromial distance. All these things I will be discussing in my subsequent videos. We have to check for the vocal fragmentus, tactile fragmentus, tenderness, subcutaneous emphysema, rib crowding, bony tenderness. Vocal fragmentus is a vibration that is transmitted through the body when a person speaks, and it can be detected as a tactile sensation on the chest wall, and this is increased in pneumonia, lung abscesses, and decreased in pleural effusion, pneumothorax, emphysema. I will be discussing these vocal fragmentus and tactile fragmentus in my next videos. Similarly, when we are doing percussion, we have to check for shifting dullness, tidal percussion, drop space, chronic isthmus, liver dullness, liver span, hard butter on the right side and the left side. Percussion is to be done on both sides, right and left, in supraclavicular area, clavicular area, infraclavicular area, memory area, axillary area, suprascapular area, interscapular area, infrascapular area. This chronic isthmus is the area of resonance which we can see in the figure. It is bounded medially by the neck muscle, laterally by the acromioclavicular joint, anterior by the clavicle, posteriorly by the trapezius. We have to percuss medially from the acromioclavicular joint. Normally it is 5 to 7 centimeter. It is narrow in TB and fibrosis and wider in emphysema. Drop space is crescent shape area on the left side of the front of the chest wall. It is formed by the lower edge of the left lung, anterior border of the spleen, left costal margin, inferior margin of the left lobe of the liver. If we do the surface marking, the left sixth rib superiorly, left mid axillary line laterally, left costal margin inferiorly. Similarly, when we are doing auscultation, we have to check for breath sounds in all the areas, whether they are vesicular, bronchiovascular, bronchial, and we have to comment on the intensity of the breath sounds, whether they are normal, increased or decreased. Similarly, this is the vocal resonance. Vocal resonance is the lung sound which are heard with the stethoscope. We have to hear it in both right and left side, supraclavicular, in clavicular, infraclavicular, memory, axillary, suprascapular, interscapular, and infrascapular areas. We have to check for any other adventitious sounds like crepitation, ronchi, rubs. We can do additional tests like Quine test, bronchophony, egophony, whispered, pectoral equi, suction splash, post-tussive creps. Bronchophony is when the lung sounds they are heard loudly with stethoscope. We ask the patient to say 999, and when we apply stethoscope, the area where there is a consolidation, we heard it louder as 99 that the patient speaks. Echophony is the increased resonance of the voice or the sound. It is increased in lungs and consolidation, lung consolidation and fibrosis. Whisper pectoral is when we ask patient to whisper something in, or just whisper like 1 2 3, and we hear it with stethoscope on the chest wall. This is called whisper electroly. It is clear and loud in cases of consolidations. Others, while after doing the respiratory system examination, we have to inspect, palpate, auscultate all the cardiovascular and the GI system also, and we have to do the nervous system examination also, like higher mental function, cranial nerve, sensory system, motor examination, various reflexes, cerebellar system, and meningeal signs are to be elicited. So once a history and physical examination is complete, we will do the anatomical diagnosis, pathological diagnosis, and etiological diagnosis. Anatomical diagnosis means if the lung is involved, which one is involved, right lung or left lung or bilateral, whether the upper, middle, or lower lobe will involve, whether pleural are involved or not. If we make the pathological diagnosis, whether it is a consolidation, fibrosis, collapse, obstructive lung disease, or restrictive lung disease, pneumothorax, etiological causes like tuberculosis, bronchogenic carcinoma, smoking, occupational or trauma. Similarly, we have to comment on complication like respiratory failure, carpulmonale. For example, if we take the example right middle lobe fibrosis, post-tubercular etiology. Right middle lobe fibrosis is the anatomical, post-tubercular fibrosis is pathological and etiological, and with the evidence of respiratory failure or carpulmonale is the complication. In this way, we have to make the diagnosis. Mark Twain has said, kindness is a language which the deaf can hear, the blind can see. With this, I conclude my today's topic. In the next coming videos, I will be talking about the cardinal symptoms of the respiratory system like cough, expectoration, hemoptysis, and many more in my subsequent videos. Thank you. Keep learning.